These practice problems will help check your understanding of content in the fourth module from the course, including study designs used in epidemiology, appraisal of epidemiologic study quality, and data interpretation. I'm going to read each question and then I'll put up the little pause icon so you can stop the video and answer the question on your own and then continue on at your own pace. An underground deposit of a previously unknown substance contaminates the groundwater used as a drinking water source for some residents of a village. It's unknown whether the substance will have any health effects or if it's safe to drink. Researchers enroll 100 people who are exposed to the substance and 200 people in the same village who get their drinking water from another source. The researchers interview each person about their health history, place of residence, place of work, and what they eat and drink at the start of the study. This study can best be described as a cohort study. It's not a case control study because it's the exposure that has already happened, not the disease or the outcome. For a cohort study, we have the exposed people and the unexposed people, and we follow both groups and monitor for the development of the disease or outcome of interest. Following the anthrax outbreak in reindeer discussed previously, the research team conducted a serosurvey to determine effectiveness of the anthrax vaccine in animals they immunized the year prior. They tested 913 blood specimens from reindeer vaccinated against anthrax and found that 814 had a protective antibody level. They reported this as a population protection level of 89%, with a 95% confidence interval of 87 to 91%. This is an example of which type of study. Cohort study is the best answer because in this example, the vaccination that they administered 1 year prior was the exposure, and then they followed the population of reindeer and then reassessed them for the outcome, which in this part of their study was a protective antibody level against anthrax. This question's a little tricky because that study also involved the actual anthrax outbreak, but specifically with the vaccination part of their study, a protective antibody level was the main outcome they were looking for. The reindeer were selected to be study subjects because they're the same animals the team vaccinated previously, so they were selected based on their exposure status. This is different from a cross-sectional study where exposure and outcome are assessed at the same time and members of the population are included regardless of their exposure or disease status. Jane was recently diagnosed with fibromyalgia. She's interested in how past environmental exposures may contribute to the risk of developing fibromyalgia, and she'd like to participate in a research study to help further the understanding of the disease. Which type of study on environmental exposures and the development of fibromyalgia is Jane most likely to be able to participate in? She could participate in a cross-sectional study. She also could obviously participate in a case control study. The reason why nested case control study is not a correct answer is because for a nested case control study, the case and the control are both from the bigger cohort study, and she wouldn't be eligible for a cohort study about the relationship between environmental exposures and the development of fibromyalgia because she's already developed the disease. The same is true of a case cohort study design. That design differs from nested case control in the way that controls are identified, but is also a sub-study within a larger cohort study. Cross-sectional studies use a sample of the population that includes people who have the disease, who are prevalent cases, so Jane might be included in such a study despite already having been diagnosed with fibromyalgia. You volunteer to provide public health assistance in the Federal District of Brazil, which is in the midst of an unprecedented dengue outbreak with a prevalence of 14%. Your team wants to determine what risk factors are associated with dengue in this population to inform development of public health interventions. Which study design would be best for identifying factors that increase the risk of contracting the infection? Case control studies start with people who have the disease, the cases, and people who don't have the disease, the controls. then look back at exposure histories to identify factors associated with an increased risk of the disease. Case control studies can be helpful in infectious disease outbreaks because they can be conducted relatively quickly compared to other study designs used in epidemiology and provide insight into associations that can guide interventions to stop the spread of disease. It's usually feasible during an outbreak to interview people with the disease about their recent exposures and also interview people from the same community without the disease about their exposures to determine if there's a factor such as outdoor occupation or residence near standing bodies of water that may increase the risk of getting the disease. A randomized controlled trial isn't a good option in this scenario because it wouldn't be ethical to randomize people to different possible risk factors and then follow them to see who gets the infection. For example, if you suspect that working outdoors near standing bodies of water may increase the risk, it wouldn't be ethical to then randomize some people to work as rice farmers or to spend time outdoors every day near wetlands. To better understand factors that lead some people to be at higher risk of dengue than others, a case control study was completed. The researchers reported a relative risk of 1.4 for dengue among residents of the federal district employed in the agricultural sector. What's wrong with this? You should never directly report a relative risk for a case control study. Odds ratio is the estimate of relative risk used for case control studies. The researchers shouldn't have claimed to have determined a relative risk based on their case control study. Remember that odds ratio provides a good estimate of relative risk for conditions that are rare, but it will exaggerate the difference for more common conditions. A clinical trial for a new cancer treatment enrolls 129 patients. At the end of the trial, 47 patients have died. The researchers report the risk of death for study participants was 36%, and the odds of death was 57%. What's your interpretation of this? The researchers are misreporting the data because the risk of death and odds of death should be similar since the incidence of cancer is less than 10%. Or this makes sense because the risk of death includes all study participants in the denominator because all the patients were at risk of death, but odds only has the survivors in the denominator. Here's the difference between risk of death and odds of death for this example. Risk of death is the 47 patients who died out of all the patients who were at risk of death during the study, 129, for a risk of 36%, while the odds of death is the 47 patients who died divided by the patients who did not die, the survivors. We find the survivors by subtracting the 47 people who died from the 129 patients to get 82. So the odds of death was 57%. A study on risk factors for preterm delivery found the rate of preterm births was 15% among women who smoke cigarettes and 5% among non-smokers. If 30% of pregnant women are smokers, what is the attributable risk of preterm delivery associated with smoking? This question is asking about attributable risk, which you should recall from the outbreak investigation lecture. Attributable risk is the proportion of disease incidence in the exposed group that can be attributed to the exposure, which we find by subtracting the incidence in the unexposed, the background risk, from the incidence in the exposed. The incidence of preterm delivery in women who smoke cigarettes, the exposed, is 15% or 0.15, and the incidence in non-smokers, the unexposed, is 5% or 0.05. So we subtract 0.05 from 0.15 to get an attributable risk of 0.10 or 10%. This means 10% of preterm births in this population can be attributed to smoking cigarettes. A clinical trial was conducted to assess the efficacy of an intervention to reduce the risk of preterm delivery. The researchers found the incidence of preterm delivery was 4% in the standard of care or control group and 3% in the treatment group receiving the new intervention. A statistical test yielded a p-value of 0.14. What conclusion can be drawn regarding the null hypothesis? Note that while appraisal of epidemiologic studies and data interpretation is a focus of this fourth module in the course, hypothesis testing and p-values are covered in more detail in the lecture titled Interpreting Epidemiologic Evidence, so I recommend making sure you've covered that content before taking the fourth quiz if you're not already comfortable with this material. The p-value indicates the intervention caused a significant reduction in the risk of preterm birth. The null hypothesis should be rejected because the intervention is effective. The null hypothesis should not be rejected because no significant difference was found between groups, or the hypothesis was disproven based on the p-value, so the null hypothesis should be accepted. If the p-value is greater than 0.05, the chance of a type 1 error is greater than 5%, so we fail to reject the null hypothesis. When this happens, the researchers should conclude their data did not provide sufficient evidence to conclude that the hypothesis difference does exist. In research studies, usually the hypothesis is that a difference does exist between the groups, so the null hypothesis is that there is no difference between the groups. In this example, we should fail to reject the null hypothesis because significant evidence wasn't found that the new intervention to reduce the risk of preterm delivery is more effective than the standard of care. The p-value tells us the probability of observing the data or something more extreme given the null hypothesis. Failing to reject the null hypothesis is not the same as accepting the null hypothesis, which would require proving that no relationship exists, which usually isn't possible. You're reading a case control study designed to evaluate the relationship between the risk of having a low birth weight infant and exposure to oil and gas industry pollution. Among mothers of low birth weight infants, the cases, 40% reported environmental exposure to oil and gas industry byproducts during the pregnancy based on geographic residence, drinking water source, occupational history, and recreational history. Among women who delivered infants of average weight, the controls, who were matched by age and parity, 20% reported environmental exposure. The authors calculated an odds ratio of 2.5. Which of the following is the best interpretation of these findings? Case control studies use odds ratio as the measure of association between the exposure, in this case pollution from the oil and gas industry, and the outcome, having a low birth weight infant. The first answer is incorrect because causality can't be established from a case control study alone. An odds ratio of 2.5 indicates that the odds of having a low birth weight infant are 2.5 times higher for mothers with the environmental exposure compared to mothers without the environmental exposure. So D is the best answer because it correctly interprets the odds ratio and aligns with the implications of the study's design. Can you conclude based on this study that the incidence of low birth weight infants is higher among mothers with environmental exposure to oil and gas industry byproducts during pregnancy? Case control studies cannot generate data on the incidence of disease because they create an artificial population of cases, people who already have the disease or outcome of interest, and controls from the outset. To illustrate this, let's say the general population has a 10% incidence of the disease, and you do a case control study by enrolling 100 people with the disease as your cases and 100 people without the disease as your controls. You can't use the data from your case control study to then claim there's a 50% incidence of the disease in the general population. If a case control study has 100 cases and 100 controls, it doesn't mean that the general population those study participants are from has an incidence of the condition of 50%. A case control study can generate an odds ratio, but that's different from population incidence or risk of the disease or outcome.